All right, so for today, what we're going to do is I went over with you guys a little bit on the whole lens. I showed you guys a picture of the muscles. I gave you guys some bony protrusion and markings of the hip. And then before we started, I gave you a cheat code to kind of go over the roots. And as we come together for this lecture, think about what I just showed you on that whiteboard. Think about the muscles and the roots. And the reason why the roots are significant is when you're reading a question on a COMLEX or on an exam, it is very important that if you were provided the number of roots, that's almost like a clue to know what the muscle is, which one is damaged, which is potentially injured or compromised. Yeah. Oh, just normal is fine. Yeah. So over here, guys, first and foremost is just making sure you're very clear on some of the key actions of the hip. I demonstrated this already during the HoloLens. So hip joint, we have the flexion, extension, adduction, abduction, lateral, which is also the same as external rotation, and medial internal rotation. And the last one is circumduction. One of the general rules here is that when you have a large muscle like the gluteus maximus or the hamstrings or the quads, they're going to have multiple action because there's so many different fibers and different heads. The smaller muscles like the quadratus femoris, easy, lateral rotator. Piriformis, lateral rotator. Those are straightforward, but the bigger the muscle, the more functions or actions it might have with. And then some of these are going to be limited. So right here, the first slide that I have that's critical is we have 3 key ligaments inside the hip region. And I try to highlight this during the HoloLens is that these ligaments wrap around the hip, the femoral head to the acetabulum in a different orientation. So the first one, the iliofemoral, this one attaches more anterior superiorly. The main function is that its job is to limit any kind of super extension. So when a patient comes in and they can extend beyond the natural range of motion, what that means is then chances are there could be a weakening of this ligament. Okay, and there's 2 kinds of range of motion, one called passive, one called active. Passive is when the patient themselves perform the motion. If they can raise their leg, that's a passive range of motion. That's good. Active range of motion is when the patient is lying on kind of a bed or being worked on, and then the practitioner or whoever is going to be manipulating them activates the muscle themselves. Over here, it also has a slight role of preventing lateral rotation. And then the next one is the pubofemoral ligament. This is the one anterior. This one is going to prevent 2 motions, over abduction and over lateral rotation. So if you look at the slide, you'll see that both of these work together to limit the lateral rotation. So in cases where the hip joint is weakened and you could hyperlaterally rotate, there's potential damage to the ligaments. And the last one will be the ischiofemoral. This one's going to attach from the acetabulum to the femoral head and approach to the neck. And this main function is going to prevent medial rotation. The picture's okay. It's not perfect because it's too deep, but you can see on the left side, this is the anterior view. The fibers of the iliofemoral ligament goes down from the upper region. You can see the spine, so the anterior iliac spine, even parts of the intertrochanteric line, and then touches the upper part of the femur, the line between the two. Okay, right here, this is the iliofemoral. And then on the anterior side, right lateral to the pubic symphysis, this joint, is going to be a pubofemoral. So the question is, can you see the ischiofemoral in the anterior view? No. You can't see it. You can only see the ischiofemoral on the posterior view. All right, so this is an example where having a 3D model, especially the HoloLens, you can walk around, is very, very helpful. All right, next one. So over here, just again, comparing this to a cadaver, and for the practical questions that I will provide on the final, I will be using the cadavers. Okay, so the 2 slide deck that I have on the Brightspace, I'll show you guys that as well. But those are the images I will use. You can look on the right side that if you look at a cadaver, it's very, very hard to spot, right? It blends all together. You can't really make out the fiber location, the orientation, but just based on the kind of the proximal area, the iliofemoral is a little bit superior, it's a little bit higher. The pubofemoral lies a little bit lower, more anterior, and then you would have to turn around to then be able to see the ischiofemoral. Another one that you're not seeing is the one inside the head, the fovea. And then on the left side, you also still see a little bit of the membrane, the obturator membrane. This membrane also is what literally sits next to the piriformis and right behind the obturator nerves. Okay, the obturator nerve is the one I have on the bottom, the IIGLOF. okay, the lumbar plexus. All right, so this is a lot of visuals. Next one, some of the supporting functions of the hip, including the articular capsule. That's just a accessory structure that helps you maintain, keeps the head in a capsule, keeps the head and neck enclosed. We also have a series of reticular fibers. I can see it's actually really small, but these fibers surround the bottom end right here of the neck and on the top part of the neck, right on the base. There's a small little groove around the head. So you can see there's a little bit of space, and the synovial fluid and the cushioning makes the socket healthy. And when you're young, this joint is pretty filled with fluid. There's hyaluronic acid. It's nice and cushioned. But as you get older, and as that fluid drains, and as the ligament wears off and the articular surface wears off, the bone then touches the bone. And as that happens, it generates friction and pain. So as you get older, there's an inevitable fate of hip deterioration. It's going to happen. And it's really just how you use it. Do you over abuse it? Do you overstretch it? I think, again, just don't overstretch if you don't need to. You're just weakening the ligaments. The ligament teres, this is the one I mentioned right in the head. Tiny one has zero function in terms of action. It's strictly just for support. Okay, the ligament teres, that's the one right from the head. If you look at the picture over here, you should see that there's a dip, a concave space right there on the middle of the head that you didn't see on the hollow one. So right here, this is where the ligament teres is going to attach to, directly socketing into the acetal bone. This is also where they would put the titanium rod. So when you hear about arthroplasties, the hip replacement surgery, they drill in a titanium rod. That will be the anchor point. That's where the screw would go in, and you would then attach it to the fovea. All right. So again, another picture. Take a look at it when you have time. All right. So over here, the pelvic girdle. I went over a little bit on the cipher between males and females, but the pelvic girdle is the combination of your sacral with the two ossicoccygeal bones fused together. This bone forms this basin ring. You can see on the front end, we have the pubic symphysis. On the posterior side, you have that sacrum with the coxa. This is a pretty cool picture comparing the males and females. I did point out a few key traits, and I think this is good to know. Number one, the pubic angle. So less than 90 degrees, that will be a male. Greater than 90 degrees, usually male. The inlet itself, just the sheer size. So if you look at the picture, and just the size of this inlet, you can see it's way bigger than the upper one. That's going to be for a male on top, and the inlet on the bottom for female, hence for the ability for the delivery, right? And then the movement of the baby. And then over here, the coccyx, that little head, the little tailbone, is pointing upwards in a male. It flips up, and then for a female, it's a little bit more vertical. You can also, I guess, you can't really tell by the size because, again, there could be discrepancies there, but the sheer inlet and also the angle should be able to give you a pretty concrete idea of what is. Here are some of the bony markings that you should be aware of. And as always, whenever I have the slides, just look at the ones that I put a star to and highlight. Those are the key slides I want you to know. Make sure you know the ilium. This is the upper, kind of a smooth, flattened surface that includes the crest and the fossa. We have the ischium. That's parts of the main body and the ramus. That houses two key protrusions, the tuberosity and the ischiospine. And then the pubis is the anterior region that includes a couple of structures, the inferior and the superior rami, the pubic crest, and also the tubercle. This picture isn't the best. I know it's a little bit lower resolution, but you can see, and what I still like is because it's a black background, so it has a little bit of contrast. But just be aware that the spine location, make sure you're aware of which view you're looking at. So this is a pretty good view anteriorly positioned. And when we think about the pelvis, we describe the two regions, the superior region, the upper part, the greater pelvis, that's the upper inlet. And on the bottom of it, where you house the bladder and the uteries and the organs, that's your lesser pelvis or the true pelvis. So that's just the two divisions where some of the structures are located. And in this, you can see the model here that's actually kind of posing when you actually do like a checkup. For example, if you go to OBGYN, you do your pap smears, one way for a health checkup when you're dilating or to check the health is you can actually palpitate the coccyx. So going through the vaginal canal, you can actually measure the distance and also whether or not the coccyx is ideal for delivering a baby. Maybe there's some deformities in your coccyx bone, or maybe it's blocking the inlet. That might reduce the chances of natural delivery, and you might have to offer a C-section. But these are some things to be mindful of because of that inlet location. Okay, I listed the sexual differences already, so we're just going to jump over this one. This is a nice chart. I like to do a lot of charts when you go into medical school, and most of the students are so grateful for this because there's so much material. And this is a nice cheat sheet for you to look at when you compare males or females. Here are the general characteristics. Number one, if it's bigger, I don't really like the first one because different sizes are going to be found in both genders, but thicker, bigger density, you're going to generally be for a male pelvis. When it's deeper, it's usually going to be for male. And then on the bottom, I think these are probably the better ones, is the pubic angle right here. The less than 90 degrees usually is going to be the male. Clearly greater than 80 degrees will be for a female. And then the inlet. So smaller inlet is for male. Larger inlet usually is going to be the female. This one's also not bad as well. The obturator foramen, when it's very, very round and when it's a little bit more symmetrical, typically it's found in males. And then when it's more oval or elongated, it's typically for the female. Okay. And the last one is the acetabulum. So the lower leg, because typically men have a little bit more bone density. The femur might be a little bigger, so that the femoral head is slightly bigger, and so the acetabulum is slightly larger. So the last two are good ones, but if you were to ever see across like a pelvis by itself and you're trying to identify male, female, and you're a doctor, and somebody's probably going to ask you that, and you probably think you should know, there you have it. Okay, so these are some of the characteristics that identify pelvis strictly from the size. Okay. Now, in the pelvis, there are some blood supply. This is a key slide. The difference between males and females is quite straightforward, not too bad. We all share the same vessels, except for one set. The females have 4 key arterial supplies. The males have 3. And as you can see, the only one that the males don't have is which one? Is the ovarian, right? We don't have ovaries, sorry. So we have the testes. So we don't have the paired ovarian arteries. And then, but we do share the internal iliac arteries. We also share the median sacral, and we also share the superior rectal. Okay, so this is the only differencing artery blood flow. And then for the venous drainage, exactly the same. There are several plexuses to be aware of. So in the lower pelvic region, we have the rectal, vesicular, and for the males, the prostatic, and for the females, we're going to have the uterine and the vaginal. Okay, so just be aware. I'll put a little circle here. But for the prostatic, that's the vesicular, and the prostatic, that's for the males. And then I'll draw a little symbol like that. And then for the females, it's going to be the uterine and vaginal. Okay, so that's a slight difference there, but the blood supply isn't too tricky. I like this view because it gives you a pretty good sagittal map. If you're looking at the picture on top, the common iliac comes down. It branches, bifurcates internally to the internal iliac. And this outer one is the external iliac. Then the external iliac wraps around the posterior region, gives rise to the gluteal arteries. And on the anterior side, it gives rise to the uterine for the females. And on the anterior, it gives rise to the umbilical / the epigastric arteries. Okay, so if you're watching my drawing, the yellow-orange kind of color, you can see it's maps to the posterior, anterior. I think the best way to know the arteries is know which ones flow anteriorly to the front and which ones kind of curve towards the back. That's the easiest way to map it out. Again, this is a 2D picture, so it's not showing you the lateral aspect. You can't see where it's branching out towards the lateral side of the body. Okay, so let that sink in. Veins on the bottom, you'll see a comparison of males and females, but it's very similar. So on the top, we have number 1 coming through, and then we have the uterine, the main one difference, and then the vaginal. All right. Now, mapping with that is we also have a little bit on lymph nodes. Don't stress out about the lymph nodes. I do want to paint the full picture so you see it. The lymphs always drain opposite of the blood flow. So everything you're seeing on the picture is going from bottom up. Right? It's the counter flow to the blood vessels. The color is pretty cool. You can see lymphatic drainage is not as clear cut as blood vessels because they're not as integrous. But you can see on the bottom we have the pink one. These are the lumbar drainage site going from the bottom of the picture. Where's my mouse? There we go. There we go. Okay. So on the bottom we have the lumbar. Lumbar is in pink, going upwards towards the upper pelvic region. We have the sacral, and then moving up to the orange region, we're gonna have the common iliac. But it literally shares the same terminology as the arteries. It just counterflow. So when you're going through the list, remember the flow is always going to be from bottom up, not top down. So whenever you're trying to memorize or study and associate these vessels, The arteries and veins, you should go from superior to inferior. That's a kind of a nice way, bigger to smaller. And the lymph nodes, you always go from the bottom up. Okay, so the exact opposite. So if you know the arteries, just flip it around, you will have a general map of the lymphatic drainage. Okay, now one clinical application for this topic is the hip dislocations. And I think this is valid because it's good to know that they're not all the same. The classification system is not relevant for this class, but as you progress in medical school, you'll see that there are different types of fractures. They're classified by type 1 to type 5. That depends on the severity and how displacement occurs. And in dislocations, oftentimes it's really based on the location of the head. Okay, so if you look at the picture, type 1 is when the head slides out of the acetabulum slightly superiorly. Type 2 is when the entire head is off of the socket. So you can see it's out of the socket. Type 3 is that it's actually protruded and damaged the hip bone, where there's fractures on the hip, and the head is still integral. Type 4, look at this one. The head has penetrated through the pelvis, right? So if there's a reason, if you're that person that likes to kick your leg up in the car, like you're in the front seat, and you kick the leg up in the dashboard, you're that person in the front passenger, and you get in a car accident, you will get this, okay? You know what I'm talking about? People that like to kick their leg up in the front dashboard. I hate people that do that. If you ever get in a car accident, you are going to lose your femur. And it's in the worst case scenario, maybe in type 4, type 5, where the femur head gets jammed up into your pelvis. And that's going to be an interesting repair. Okay? So you're going to be not able to walk for a long time. So a lot of times a high trauma injury, especially when your leg is hyperextended or flexed, there's a chance where it pushes upwards. And in most times, and this is just a general trend, is that in the car accidents that do occur, 85 to 90% of this happens posterior dislocation, where the hip will jam posteriorly. Okay, and that's based on the weight distribution, but that's what oftentimes happens. Everybody know what I'm talking about, right? You're sitting in the car, or you're the passenger, or you have a friend that likes to kick their leg up, and imagine at that moment you slam into something, right? Just imagine that, and then your leg, your femur, shoots upwards behind the back of your hip. All right? Pretty brutal, right? In some cases, you might even just fracture the hip, or the femur is completely out. Okay? So that could happen. Anyways, type 1 to type 4. And then, of course, we also have the head fractures. So when you think about the femoral head itself, or any kind of arthroplasty replacement, this is a pretty common incident, especially in the country. Oftentimes when you're older than 60, because of bone density deposits, and then when you hit menopause and you start losing the ability to have that strong bone, there's a higher chance of having fractures. And the femur is pretty weak over time. Let's say you have a fall, or you hear about elderly falling, and that is life-threatening. But the way that this happens is when you tear the main artery, the medial circumflex arteries on the head, or the reticular artery, they oftentimes are the main culprit. That bruising occurs, it starts bleeding. In a worst-case scenario, when the blood vessels don't heal, and then there's accumulation of blood over time, and maybe no lack of maybe some kind of wound or bacteria accumulating, you're going to have AVN. AVN is the end game. That's when you have tissue death, and in some cases, you have to completely sever the bone and replace the bone. This is known as avascular necrosis. In the picture, you can see in this scenario where you have this healthy, normal cartilage surrounding the hip. You have a hip fracture that's not really anything life-threatening, but then because of the bleeding and because of the injury, infection, it leads to necrosis. And that necrosis leads to the tearing down of this area, and it never gets treated, right? You're living with this damaged hip, and you see your grandparent just kind of limping or having the eve drop. It's called the foot drop, by the way, where the foot dangles down. And by the time you know it, it's already necrotic. And at that time, the only thing you can do is to cut off the bone and completely replace it, right? Or you're just wheelchair. You're not going to be able to walk. You have to have like a crutch or maybe wheelchair bound. But again, this is a complication that occurs. But typically, it starts with the medial circumflex femoral artery. That's the main one that supplies to the head region. And it makes sense, right? Because that's probably the weakest area. If you think about the femoral head, we talked about which area do you not want the fracture to be located? Which will have the slowest healing process? The head and neck, right? So if you think about it, right between the head and neck, if this area gets damaged, it's compromised. If you damage parts of the trochanter, maybe parts of the shaft, right? Especially the shaft of the femur, there's good blood flow. You're still going to recover pretty good. It's easy to work with. But when you damage the head or the neck, you're compromising the joint and the integrity of the connection. Okay, good. All right. Now, moving forward, We also have some structures on the interior side of this upper hip region. This is called the functional femoral triangle. And this is important because this triangular region, I know you can kind of see it. I'll draw this out. If you draw a triangle in the medial aspect of the thigh, you can create this little window. On the top, you have the inguinal ligament, and on the lateral surface, we have the sartorius. And on the medial surface, we have the adductor longus. This is a clinically significant region because when a surgeon or a person's going in to graft something, if you're going to access the vessels, put in the contrast dye to the femur, whatever you're doing, this triangle is a map for surgeons to guide where things are located. Okay, so once you locate the femoral triangle, you will know it houses several structures. The great saphenous vein axis is right there. The femoral nerve axis is right there, the femoral artery, and also even parts of some of the key origins of the muscles. So this is a significant location for a surgeon to know where to go in to access which nerves and arteries. For this topic, just be aware that the three borders are inguinal ligament on top, adductor longus medial, sartorius on the lateral. Okay? And if you're curious, what are some things behind it? Here we have it. Include number one, the femoral nerve. This is the largest nerve of the lumbar plexus. I gave you that cheat sheet over there. And what's the nerve roots of the femoral nerve? 2, 3, 4. Really good. Okay, so that's what you got to know. So when I say femoral nerve, that's your L2, L3, L4. And then it also includes a sheath that covers over the nerve, the femoral sheath. The femoral artery that then gives rise to your lower leg, the popliteal artery. This is the main supply of blood flow to the leg. We also have the femoral vein that gives rise to the inguinal ligaments, posterior to the inguinal ligament, but also gives rise to the external iliac vein. And the last one is the obturator. Okay, the obturator passes through the obturator foramen. I want to highlight this. When a fracture occurs anteriorly to the hip bone and you compromise the obturator foramen, then that means which nerve is damaged. If you were to crack parts of the obturator foramen and now there's lesions of the bone fragments begin to accumulate, you're going to risk damaging which nerves? The femoral and obturator, right? So 2, 3, 4 are all compromised. So there's overlap. That's why it's really tricky with the nerves because you can see on the map that I showed you, the 4, 5, 1, 2, 3, even though sciatic nerve is the main boss nerve, they overlap with all the other nerves. So in patients that have any version of any damage to the lower leg nerves, you're going to have some kind of weakness, right? And unfortunately, guys, if you ever break your leg or break your hip, will you ever have the same function? Will you have 100% nerve function? Probably not, right? You'll probably have some activity to rehab and control the muscles, but that nerve conduction signal is never going to be perfect again. And as you get older, preserve your nerves, preserve your ligaments, because you only, unless you want to be wheelchair bound or bedridden, take care of yourself. All right. So over here, next one is the lumbar sacral plexus. Here we have it, the nerves. I went over that cheat sheet already. So this is between L1, L2, L3, L4, L5. I like this picture because it maps it all out for you. So you can see on the left-hand side, the anterior ramma is the orange region. This is the anterior located nerve roots. And then we have the posterior division. They branch out to the posterior side. And then on the anterior division, we have the blue one. This picture is not ideal because it's meant to be 3D, but it's shown on 2D image. So the roots are as follows. It's going to be from the spinal nerves of L1 to L4, and then they generally will supply regions of your lower abdominal wall. I also went over the external genitalias, mostly the skin. Okay, so when we say the external genitalias, make sure you're aware there's the differences between the males and females. When we say the females, we're referring to the mons pubis, the external vagina region, parts of the labia. For the males, we're referring to the skin of the scrotum, parts of the testicular shaft, and regions of the upper dartos muscle. So again, different structures, even though we're referring to the external genitalia. And then on the right side, I have then the sacral, lumbar sacral. So L4, L5, and then you see the S1 to S4. Okay, this is the one that has the 4, 5, 1, 2, 3. SGN, superior gluteal nerve. IGN, the unique one is a nerve to the piriformis. What's the nerve root for the piriformis? What are the numbers? S1, S2. Okay, make sure you know if it's S or L. S1, S2. And then we have the sciatic nerve. And next week, we're going to go into the common fibular division and tibial. That's going to control all of the everters, dorsiflexors, the lateral compartments. So, for example, your tibialis anterior, your tibialis posterior, your peroneus longus, the ones that move your toes, your small toes, that kind of stuff. And then just like you remember with the upper limb, the skin of the lower limb is also not symmetric. Okay, that's the part that's going to be kind of tricky next week, is that unfortunately we love the nerves and they're pretty cool, but it's not proportional. It's not like this nerve goes to just the exact half of the foot. There's for example, the common fibular nerve that runs down off of the sciatic nerve. That only gives you sensation between the first two toes web space. So it helps you feel the sensation along the medial big toe and the medial second toe. That's it. Small little area, small like 1 centimeter, 2 centimeter space between your foot only gets perception from that one nerve. Okay, just like your hands. Remember, you guys went over the medial nerve, the radial nerve, the ulnar nerve. It's not symmetrical, right? Right? Remember this one? The radial nerve and the pinky, ulnar nerve. So it's not symmetrical. It's not evenly divided. Okay. So over here, highlighting some of the key nerve functions. The femoral nerve is on the posterior side. The main nerve, it innervates mostly the anterior thigh muscles. We'll go over the muscles in a second. It also provides sensory input from the anterior / the inferior medial aspects of the leg and the skin. The abdurator is going to go from the anterior side, and this one is the main plexus that supplies the medial thigh muscles. It also provides information from the superior medial skin of the thigh. And then we also have some of the smaller ones that kind of expand out that we're not going to have a name for them, but the nerve roots can then attach to the abdominal wall. Okay, this is that cheat code. So IIGLOF. I twice get laid on Friday. So 1-1, L1, L1, L1-2, L2-3, and L2-3-4, 2-3-4. Please be aware that obturator is slanted more anteriorly, whereas the femoral nerve is located more posteriorly. Okay, this is one of the small differences that when you're looking at a cadaver one day, or when you see a three-dimensional model, the nerve roots all look the same color, right? You won't be able to decipher from coloration or location. Just know the anterior or posterior. All right. And then within the sacral plexus, we have the main nerve, sciatic nerve, and pudendal. Sciatic nerve is L4 to S3, and it supplies the posterior thigh muscles, parts of the foot, and then the main marking, the main landmark. When you're going through surgery, when you're operating on somebody's lower leg, you're looking for the greater sciatic foramen, the greater sciatic notch. That's the guide to see where that nerve runs. And that's also why I said earlier that when you're sitting for a long period of time and you have a sudden weight gain, pregnancy, unwanted weight gain, that shift in weight and you're sitting for a long time will compress that notch on the muscle. The muscle gets inflamed, the piriformis, and then your nerve gets pinched. Whenever the nerve gets impinged or pinched, you're going to have this tingling feeling, numbness, paresthesia, weakness. The muscle function is going to be reduced. And then the one below that is your pudendal nerve, S2 to S4. Main function is to supply the external genitalia. And then let's actually write two other muscles. So the other two muscles are going to be your external urethra sphincter and the external anal sphincter. So these are the two round muscles that control defecation and urination. When you get older, and as you weaken the pelvic floor, or if you have a hip injury, what happens to elderly patients? Incontinence, right? And it starts with this. So when the nerve gets impinged or weakened, and it doesn't have the ability to control the sphincters anymore, it's going to start leaking. Okay, so this is where it all begins. So that pudendal nerve is what controls the EUS and EAS. All right. Pretty cool, right? And on the right side, you can see a pretty nice map of the sacral plexus, the L4, L5. I know it looks really confusing, but just be aware that some of these nerves bend anteriorly and some of them will bend a little bit slightly posteriorly. Okay? And I'll try to make it simple, but this region is very delicate. You can just see how intricate the webs of nerves are. And look at that piriformis muscle. Okay, the spine right there, but the piriformis is going to be sitting right through it. It's very, very common whenever the muscle gets inflamed, or if you're in a bad posture, or if you're over squatting, you're just doing too many leg workouts, and then you shift the muscle, and then nerve starts pinching, and then it's done. Right? So that's when you know, like when you feel that tingling sensation, something's off. All right, so here are some of the key points of the lumbar sacral plexus. SGN, L4 to S1, supplies the following muscles: gluteus medius, minimus, tensor fasciae latae. IGM, L5 to S2, supplies the gluteus maximus. I also added a few more, so that I think that's more comprehensive. And then the PFC. Out of all of them, the only one, or maybe the second time, third time, that doesn't supply any muscle, posterior femoral cutaneous. Okay, this is the one that only supplies the upper medial regions, bless you, posterior regions of the thigh, and the pudendal nerve as S2, S3, S4, perineal structures, the genitalia, the perineal floor. Think of the two muscles, bulbar spongiosus and ischeminosus. Think about erection for the males, erection of the clitoris or the penis, same thing. Okay, so that's the structures right there. All right, and then last, before we take a break here, is we also have some autonomic supply. All right, those are the key roots and nerves of the muscle. Autonomic nervous system is different because they run very closely to the roots, but they don't directly control muscle. They control the responses, blood flow, the way the constriction occurs. So we're going to have the sacrosympathetic division right at the lower limb. We also have parts of the hypogastric plexus. That's going to innervate the genitalia organs for ejaculation, the dilation of the vessels to maintain the erection. And then we also have the parasympathetic output from S2 to S4 that runs alongside. Remember, the upper cranial region and the sacral region goes to the parasympathetic. Thoracic lumbar is sympathetic. And then we also have parts of the periarterial plexus that's also a sympathetic subdivision. There's no clear number or map. It's just these are webs of nerves that run very closely to the main lumbar sacral region, but they control the glands, they control the blood flow, constriction, dilation. All right, so let that sink in for a little bit. When you're looking over the slides, focus on the slides I have the high yield. Okay, so I give you some other slides as well to fill in the whole picture. But when you're studying this, just focus on the stuff that I've highlighted in bold